So the last time you coached a patient or client through a posterior pelvic tilt, how would you rate your performance? Would you say that you were confident, fairly confident, or had no idea what you were doing? If you had no idea what you were doing, then you're not alone. This topic and really this exercise or movement is really a problem and trouble area for a lot of coaches and clinicians. And a lot of it comes down to the language we use and our patients' unfamiliarity with controlling their pelvis and really mobility with their pelvis. So in this video, I want to break down how we can change our language, how we can better coach this so that you can become very confident and get the outcomes that you're looking to get with your patients and clients. So we first need to understand basic biomechanics of a pelvic tilt. We need to understand that there's an anterior and a posterior pelvic tilt. Anterior tilts are normally your arched backed individuals, those with increased lumbar lordosis. Conversely, your posterior pelvic tilt individuals are going to be ones that are more rounded over in more of that kyphotic position. Now, biomechanically, what we want to start to consider is that with an anterior pelvic tilt, we start to go into nutation. That nutation goes into internal rotation, adduction, and extension. Conversely, with a posterior pelvic tilt, the sacrum moves posteriorly. The result of this compression pushes that into that posterior direction and opens up the innominate bones into external rotation, abduction, and flexion. Now, I highly encourage you to check out our Performance Redefined course where we go down and break down the mechanics of why we see these things. But in the essence of time, I just want you to understand the different biomechanics for the two. Now, since we're talking about a posterior pelvic tilt, we need to understand that we need to get someone to be on their back, and we need to get them to counter-nutate, posteriorly tilt, and externally rotate and abduct the pelvis. Now, it's easier said than done, right? Like I said in the beginning, this really is a tricky area for people because they don't have the mobility and they don't have the familiarity, that awareness of how to control their pelvis. They're used to moving their whole body as one unit, where what you're doing is asking them to dissociate, right? We're trying to say, hey, Mr. Jones, can you move your pelvis but not move your rib cage or not move your thoracic spine? And that may be really tricky for them. The other thing I want to bring to your awareness is that a pelvic tilt may be something you do in the beginning with a patient or client, and a lot of us think of dead bugs, right? Understanding how to control the pelvis as you move into that dead bug motion. But the control of the pelvis is crazy important, right? Because when your patient is squatting, when your patient's deadlifting, when your patient's lunging, it doesn't matter what they're doing, they're going to need to have the awareness of how to control their pelvis and their awareness of, are they compensating and can they move out of that compensation so they can get the most out of their exercise. Now, when it comes to our language, we need to change it. We don't want to start saying, hey, Mr. Jones, we're going to move our innominate bones and your sacrum's going to counter-nutate, and then from there we're going to tuck and move in the posterior direction and try to avoid the anterior direction, right? That's what we're going to try to avoid. All we're going to do is simplify it, put it in terms that they can understand. So a very simple cue that you can use for your patient or client is to get them aware of their belt buckle, right? Hey, Mr. Jones, you see that big belt buckle you have on? Or, Mr. Jones, can you imagine you had a big belt buckle on, like a WWE belt buckle, a cowboy belt buckle, a Gucci belt buckle, something that is big? And then they'll typically say yes. And then from there, it's, okay, Mr. Jones, can you move the belt buckle away from your chin? This would be our anterior pelvic tilt. Then, because we're coaching a posterior pelvic tilt, because this individual needs it, we're going to say, okay, we want to go through the exact opposite. Now, I encourage you to start with the opposite. It just gets them to increase their movement capacity, and it makes it really easy to start to tuck, right? So what we're going to do is say, hey, Mr. Jones, I want you to go the opposite. Can you tilt your belt buckle towards your chin? That is the posterior pelvic tilt, counter-nutation, the tuck, right, that we're looking for. If they can't, get them to go through an extreme range. A lot of times people struggle with it, and what they're gonna do is as they go into that posterior pelvic tilt direction, they're gonna try to crunch, right? So they get the sensation, the awareness that their back has dropped, right? The decrease in the lumbar lordosis, but they're actually crunching. So they're not using their pelvis. Their pelvis isn't tipping back. So if we have our pelvis here, the pelvis isn't rolling back, the pelvis stays, and from above, we're crunching down. And that's what we're trying to avoid. So we really need to get people aware of their belt buckle. The more belt buckle control they can have, the easier your life will be when you're teaching and coaching this movement initially to them, whether it's a dead bug or whether it's just rolling through an anterior pelvic tilt into a posterior pelvic tilt. But again, continue to keep the bigger picture in mind to remind that patient or client that, hey, in order to optimize your squats, in order to optimize your deadlifts, right? Just think our bigger motions, even upper body motions, right? We need to have awareness and control of the pelvis. And when we can do this, your life is going to be a lot easier. Your patient is going to get better outcomes, less pain with movements, and your clients are going to perform better.